Hey guys, welcome back to my channel. Today we're going to be talking about vent modes, mechanical ventilation, the basics of what modes to put people on, and what each mode does. So if you want to know more about the basics of mechanical ventilation and vent modes, stick around to find out more. Hey guys, I'm Daniel from Doldier Media, and today I'm going to be talking about a respiratory therapy topic. But if you're also a nurse, this is something that might benefit you, whether you're in nursing school or you've graduated. So vent modes is something that's pretty advanced in the respiratory community. Usually towards the end of RT school is when you start getting into vent modes. And it's something that not many people understand when they just start school. And it's something that nurses, unless they work in ICU, are far detached from it. Now, an interesting thing to mention before we talk about vent modes is why somebody gets intubated. And we're not going to go into all of the indications to intubation, but the top popular ones are blood gas that cannot be fixed through any other means, such as non-invasive ventilation or BiPAP, or any other modalities that you place the patient on, and what you're getting is a bad blood gas, which means the CO2 stays high, the pH is staying low. And if you're repeatedly getting a blood gas that's maybe 7.20 or worse, and nothing is helping, no intervention is helping, then that's going to be a good indication that they might need an advanced airways so you can control their ventilation better by actually inserting an endotracheal tube and completely controlling ventilation. Now, other important reasons why people get intubated is sometimes they're in a procedure, and after surgery or after some kind of operation, they need to maintain their airway because they're heavily sedated. So a post-op patient is going to usually come out on an endotracheal tube. We're going to put them on a mechanical ventilator until they start waking up. We do a quick few tests, and most likely they're going to get extubated within 24 hours. But that is another reason that a person goes on a mechanical ventilator. Another very common reason why somebody might have an endotracheal tube and they'll need a vent being placed on them is airway protection. Now, airway protection is something that's a little bit more subjective in terms of when a person needs to get an endotracheal tube or get intubated. And airway protection is going to go along with if the RT, the MD, or the RN thinks the patient can't clear their secretions, they can't cough safely, or they're not able to protect their airway, and they're going to eventually either choke or something else is going to happen that the person might risk their life. So it's better to prevent that, and until we fix that problem, they're going to have some kind of artificial airway where we can control their ventilation. Now, in these kind of situations, somebody that has like a muscular dystrophy disease like ALS, or if somebody has MS, or if somebody has Guillain-Barré, those people are going to be put on a ventilator for airway protection. It's also going to be linked to respiratory failure, but a lot of times you're going to do it before they get into that respiratory failure stage. And respiratory failure is a tricky thing. A lot of hospitals determine what that means in a different way. But typically, respiratory failure means you're not able to blow off the CO2 appropriately. And there's also a lot of other objective things like increased work of breathing or some kind of altered mental status due to CO2 hypercapnia. So now that we talked about reasons to get intubated, now let's talk about the modes you might put these patients on. So the modes you're going to put the people on are going to be split into two groups. And let's talk about that right now. So you have one group, which is volume control mode, which is right here, or pressure control mode, which is right here. Now I'm going to go over the difference between volume control and pressure control, because no matter where you are in the world, that's pretty much the two major differences between modes that you'll put people on. We're going to go into more specific differences later on, but if you know the difference between volume control and pressure control, you could pretty much figure out a vent anywhere in the world. Whether it's a German Draeger or any other kind of country's vent or an American vent, you're going to know what to put a patient on. So the first separation in modes and difference is volume control versus pressure control, like I mentioned earlier. Now, volume control mode is a mode where you completely take over giving the patient volume as opposed to giving them a pressure gradient. Now, that's a little confusing if you don't know what this means yet. So let me kind of break it down like this. If you put somebody on a volume control mode, imagine a syringe or some kind of a pump. And every single breath you give them Let's say the pump that you're given is about 1 liter in size. So there's 1 liter of air in this pump. On a volume control mode, you're always pumping 1 liter. Whatever the container is, you're always giving them that amount. That's volume control. So you control the volume. It's the amount of air that takes up the little container. Now, as opposed to a pressure control, instead of giving a certain amount of volume, what you're regulating is you have a manometer and you're giving them a pressure gradient. When you reach that pressure, you stop the pump. So how this works differently is if you put somebody on a volume control mode, that means that no matter what the volume you set is, the patient's always going to get that volume. As opposed to a pressure control mode, no matter what's going on with the patient's always going to get that pressure gradient. And now, in a volume control mode, the pressure is always changing because sometimes if the lungs are very compliant, what's going to happen is if you give a tidal volume or a volume of 500 milliliters, then it's going to be very easy. There's not going to be any pressure that's needed. But let's say that the lungs of the patient are getting a little bit more stiff and they have some kind of disease process like pneumonia. What happens is when you give the same 500 milliliters and you push that into their lungs, now it takes a lot more pressure and it's going to fluctuate. It's going to change. As opposed to a pressure control, on a pressure control mode, the pressure is always the same, but the volume is constantly changing. So those are the two differences you need to remember. Volume control, the pressure is always changing, and on a pressure control, the volume is always changing. Now let's use my earlier example and kind of use that to kind of explain the difference between putting somebody on a volume control mode or a pressure control mode. So let's say you have a syringe that's 0.5 liter or 500 milliliters. And you're trying to fill up a balloon. It's going to be a birthday balloon that you're throwing for some birthday party. And if you pump 500 milliliters into the balloon, it's going to inflate because it has a huge capacity and nothing's going to happen. It's not going to pop. It's going to be perfectly fine. And so what happened is that balloon's safe. That balloon's good. That's a volume control mode on a perfectly healthy patient. Now let's say that patient's lungs or the balloon is now a water balloon. It's not as compliant. It's a little bit smaller. There's some kind of problem with the balloon. And you try to put the exact same amount of air into a water balloon, it's going to pop. And now what we call that is a pneumothorax in the hospital. So there's a high chance that if you put somebody on a volume control and their lungs start deteriorating and getting more stiff and getting worse, that eventually you're going to have a risk for a pneumothorax or some kind of trauma where you can actually pop the lungs. Now, not like a balloon, but there's going to be a hole that air is going to be able to escape from. Now let's take the reverse example and say you put somebody on a pressure control mode. And so now instead of you filling up the contents of the syringe into the balloon, you're trying to fill up a water balloon, a balloon that's not healthy or lungs that are not healthy. And it's kind of stiff. It's very hard to put air into it. So you put a manometer on it and you give only a certain pressure gradient. And the pressure gradients, let's say it's 20. The pressure is 20 millimeters of mercury. And you try to fill it up and you're only able to put about half of that syringe in there, 250 milliliters into the balloon. The balloon didn't pop. It's perfectly safe. You're good. Now the problem with this mode is what if the balloon now finally gets a little bit bigger or the lungs get more compliant? So now the lungs are healthier, they're healed, they're not as stiff anymore. And now you have the big birthday balloon that you're trying to fill up with the pressure gradient. You're pumping in at a 20 millimeter mercury pressure. And what's happening is you're only getting 250 tidal volume into the balloon and the balloon's going to be flat. You're not going to ventilate the patient. So using these examples, I hope you understand the difference between a volume control mode and a pressure control mode. If your patient needs 100% ventilation and you want to control everything that's going on with their ventilation and they're healthy, the best mode to put them on is a volume control mode. But let's say there's some kind of disease process where the lungs are getting more stiff and you're worried about the pressure of the lungs and you're worried about causing some kind of trauma, then a pressure mode is more appropriate and you can regulate the pressure and monitor that instead. Now with the two big differences being mentioned, let's get into some more specific mode settings. So the first one we're going to go over is assist control, or in some vents it's controlled mechanical ventilation. It kind of depends on what hospital you work at or what vent you use, but the idea of it is that it's a completely controlled mode of ventilation, and it's usually going to be called assist control mode. Now, how the settings would look like would be like this: assist control pressure control or assist control volume control. So the pressure or volume is chosen by you or the doctor. So you're choosing how are you going to deliver each breath. And what assist control mode does is that it tells you for every single breath that the patient tries to take themselves, it's going to be a machine given breath. Now what this means is, let's give an example of volume control assist controls, or ACVC. We're going to set the tidal volume to 500. Now with a tidal volume of 500, every single time the patient is going to trigger a breath, the vent is going to be able to detect that the patient is trying to breathe, and it's going to give them a machine breath. And that machine breath is going to be the same size every single time. It's going to be 500. If the patient is heavily sedated, coming after OR and they're still getting off the sedation, or you're intubating them for airway protection or whatever is going on, you put them on a volume control assist control mode, and you could always get a guaranteed result because they're pretty much going to get what you put them on. Now, the problem with this setting is the moment the patient starts waking up or getting off of their sedation, what's going to happen is every time they trigger their breath, it's going to give them a full machine breath, a tidal volume of 500 every time they kind of try to breathe. Now, what this is going to cause is breath stacking. It's going to cause the patient to keep inflating their lungs more and more and more and more. And so what could happen as a result is they could either get barotrauma, volume trauma, or any kind of traumatic thing that happens to their lungs because they keep getting inflated every time they trigger. And the patient's not going to be in synchrony with the vent. And what's going to happen is they're either going to need to be sedated more, or something bad's going to happen. They're going to desat. The pressure is going to be so high that it's going to either cause a pneumo, or maybe that they're going to build up an autopeep so much that it's going to actually push against the arteries and they're not going to get good blood pressures. So what happens is a lot of manufacturers came up with a mode called synchronized intermittent mechanical ventilation, or SIMV. You're going to see this on a lot of vents that you're going to work on. SIMV mode is a mode to combat this breath stacking phenomenon. It's also a mode to kind of assist in weaning a patient off of mechanical ventilation. So what SIMV is as you can see on the graph on the screen right now, every time that you set the tidal volume, you also set a pressure support number, which is to give the patient what their breath is going to be. So you set the machine breath setting, you also set a pressure support setting, which is going to be the patient's own breath. And so the waveforms are going to look a little bit more like this, where you give the tidal volume, which is 500, but when they trigger a breath, it's going to be a lot smaller. It's going to be more like 300, and it's going to be their own breath. Now, this is where the cool synchronized part comes in. In synchronized intermittent mechanical ventilation, the machine now, it's not on a timed system where it has to give a breath every so many seconds, but it's going to detect that the patient triggered a breath, and the next breath will only come later on. It won't stack a breath on top of their breath. So it won't give a patient breath and then a machine breath immediately afterwards. It's going to synchronize and try to make it more smooth to see how the patient's breathing and how they're working with the vent. So this is a brief overview of two modes you might see at the hospital: AC and SIMV. Now after this, there are a few more modes that you might encounter at the hospital. So let's briefly touch some of them. One of them is called pressure support, or spontaneous. Now, spontaneous is 100% the patient's effort in terms of rate, but you're giving them the pressure support. So in a spontaneous mode or a pressure support mode, it's pretty much like CPAP. You're giving them a set pressure, so when they trigger a breath, that's the pressure that they're going to get. It's going to be kind of like a boost to whatever they're able to do. And that's going to be your best weaning mode. Most hospitals use this as a way to see how well the patient can breathe on their own. So in some hospitals, they'll do zero pressure support over a PEEP of 5 or ZEEP. And in some hospitals, they'll do a very low pressure support, like 5 or 6 over a PEEP of 5. And with that, you can kind of see how well the patient's able to breathe on their own. You're looking for a respiratory rate. So pressure support or Spont are good weaning modes or good respiratory muscle workouts. If the patient's been intubated for a few weeks and they've been completely relying on the vent to breathe for them, this is going to be a good way to get them to use their respiratory muscles to kind of start breathing on their own again. So little by little, you'll go down on the pressure support as they get stronger. You also have PRVC mode, which is an interesting mode that came out a few years ago. I actually don't know when it came out, but it's a cool mode. It's pressure regulated volume control. And so instead of setting a set pressure or a set volume, you kind of compromise. So a PRVC mode, you set a target tidal volume and then the pressure gets regulated. You have a max pressure and a minimum pressure, and the vent itself will start detecting how well the patient's breathing and auto adjust the pressure to match your target tidal volume. So it kind of is like combining the two. It's still more of a pressure mode because you're giving them a pressure, but it at least has a target tidal volume that it's trying to reach. And so that's called PRVC. It's a little bit more of a smart mode. It's a popular mode to kind of see how well the patient's, how compliant the lungs are and what kind of settings you do need to put them on. And finally, you have ASV mode. ASV mode is a pretty fascinating mode that they use at my work. It's on a Hamilton G5. I'm not sure if it's on any other ventilators, but I do know that the Hamilton G5 series does have the ASV mode. And what the ASV mode does is, it's kind of like a really smart, intelligent weaning mode. So instead of you setting a target tidal volume or any kind of other settings, what you do is you set a minute ventilation, and the patient's gonna get the respiratory rate they need and tidal volume they need based on the minute ventilation that's set into the system. So let's say the patient's only able to breathe 5 times a minute, but the patient needs to be breathing 12 to 15. The machine itself, the vent, will give them the 10 extra breaths. And let's say their tidal volume needs to be around 350, but the patient's only doing 300. So the machine's going to give them the extra 50 tidal volume. It's going to give them just a little bit of a boost for them to get the right minute ventilation so that their ABG is going to look good. It's a good way to see how well your patient is actually doing. If you're trying to wean them, you can kind of see if it's them breathing, the machine breathing, how much of the machine is it, and how much of them is breathing. So it's a really cool mode. A lot of people are not familiar with this mode yet. I think we're going to be seeing this mode a lot more often in the hospitals around my area, and I'm pretty sure we're going to see it more nationwide because it's a lot more intelligent than just putting them on just a number and leaving them there. So with this being said, now that you guys are a little bit more familiar with the modes, I'm going to go over what to put what kind of patient on. So let's say you have a patient that comes in, cardiac arrest, they're not able to breathe on their own. They are sedated now because after cardiac arrest, you did get return of spontaneous circulation, and now they're sedated, they're on some kind of sedative, and you have to control their minute ventilation to make sure that they're ventilating appropriately. And so what you're going to do is you're going to want to put them on an assist control mode most likely because you want to get a guaranteed result on your ABG every single time. And based on how well or how comfortable you are with their lungs status in terms of their compliance, you're going to put them on an ACVC mode or an ACPC mode. And that's pretty much going to give you a guaranteed ABG. Once you get a good gas, you're going to keep them on that setting and it's going to be the same every single time you do it as long as they're still sedated. Another example of this would be if somebody's in a procedure, they're under anesthesia, and an anesthesiologist is almost always going to have them on a volume control, assist control mode because they want a guaranteed blood gas every single time. They don't want to play games with their pressures and chasing their lungs. They just want to set them on something that they know they're going to be safe on and not have to worry about it. So most likely the people that are in procedures, any kind of operating rooms are going to be in an assist control, volume control mode. Now when it comes down to a patient that might be a little bit more obese or a little bit more heavy set, it's going to take a lot of pressure to give them a certain amount of volume. So you're going to want to keep them on a pressure control mode because you want to make sure that they're not going to get any kind of pneumothorax. Let's say somebody's a little bit more heavy set and it's very difficult to ventilate them because there's a lot of adipose tissue pushing down on the lungs. What you're going to want to do is you're going to want to put them on a pressure control mode. And again, I'm not teaching you what you should do. This is just something that I've experienced. And if you're watching this, this is kind of an idea of what commonly is seen in the respiratory community. A lot of people that are like that are going to be on a pressure control mode because you're going to make sure that the lungs are safe, that there is not going to be any kind of trauma to the lungs. In these situations, any time you're worried about the compliance of the lungs, which means that you're kind of worried about the rigidity of the lungs, how stiff they are, those patients are going to be on some form of pressure control mode. And like I was saying earlier, SimV is sometimes used in hospitals to wean patients when they stop getting on sedation. Some hospitals don't even go to SimV. It all kind of depends on the facility you work at. But anybody who you're worried about the lungs, like what we've been seeing with the illness in 2020, a lot of those people were on pressure control modes because their lungs were so stiff, it was very difficult to ventilate these patients. For patients that are, let's say, neuromuscular problems like MS or Guillain-Barré or any wide array of these diseases that affect the neuromuscular system, what you're going to want to put these people on, or at least what you're going to see them on, is modes like ASV or maybe even spontaneous, where you're going to want them to still work on their own. You don't want them to rely too much on the vent, and you're going to also want to monitor and see how well they're able to breathe. So if you have a patient like that, you're going to put them on a mode where you can monitor their ventilation, but you also want them working so their muscles don't get too tired, their muscles don't get atrophied. You want them to be able to breathe once you take the tube out. Now, I didn't cover every other mode. There are modes like APRV, and there's countless modes and modalities that you could put people on. These are kind of the most common ones you're going to encounter in the hospital setting. Whether you're a nurse, an RT, or an MD student, these are the modes you're going to see people on. So I hope this helps you guys. Let me know if you guys have any questions. I definitely love to answer your guys' questions. I have been answering a lot of questions with you guys. Anything that anybody asks me, I do go out of my way to try to talk to you guys and try to kind of work with you to help you with any problems you have with school, any questions you have regarding any kind of finals, anything that's going on. Don't be afraid to ask. If you guys like this video, hit that like button. Thank you guys for watching. Subscribe to my channel. Have a good day.